Hey guys, welcome to our Pediatric Trauma Emergencies lecture. We know that trauma is the #1 cause of death in infants and children. Most pediatric injuries result from blunt trauma, and as mentioned previously, children have a thinner body walls which allow the force to more readily transmit through the body contents, increasing the possibility of injuring internal tissues and organs. If you're in an urban setting, you're going to see more intentional penetrating trauma, things like GSWs and knife wounds. If you're in a more of an urban, probably rural setting, you can expect to see also forms of penetrating trauma, but mostly those are unintentional or related to hunting accidents or some type of farming-like accident. Let's go ahead and dive into some of the main components that we're going to be looking at for our pediatric patients. There are a number of trauma emergencies that you will see in the field. Everything from falls, motor vehicle crashes, car versus pedestrian injuries, drownings, penetrating injuries, burns, and then physical abuse as well. When we think about trauma, one of the main things we need to do is pay close attention to mechanism of injury. We know that falls are the most common type of traumatic injury that result from pediatrics, or that will encourage happen around pediatrics. Serious injury or death from accidental falls is relatively uncommon, but we know that children have larger heads, they're more likely to fall and hit their heads, and that poses a big risk for further complications. Now, motor vehicle collisions, this is the leading cause of traumatic death in children. Also, brain injuries and new onset of epilepsy all can result from a rapid deceleration of a car accident or some type of lateral impact during a car accident. The goal when it comes to motor vehicle accidents from a trauma standpoint for peds is really about prevention and making sure that pediatric patients are properly restrained based on weight and age. When we think about mechanism of injury related to car versus pedestrian, car versus child pedestrian injuries are more common in cities where children play close to the streets. Car versus pedestrian injuries are particularly lethal form of trauma because children's short stature tends to push them down and under the car. There's two phases of injury when it comes to a motor vehicle, car versus pedestrian. The first phase occurs when the automobile contacts a child. The second phase occurs when the child actually comes in contact with the ground or other object. The best treatment for a car versus child pedestrian collision is prevention. And so we need to make sure that we're working towards effective education and awareness components, and then be very careful of how we drive, right? Driving through a pile of leaves that's on the side of the road may seem like a fun idea until you find out that there's a child that's playing or hiding in them. We also know that with drownings is a third leading cause of death in children between the age of birth and 4 years. Outcomes are always better when the water is cold. We know we have the mammalian diving reflex, which is going to help decrease the metabolic demands of the body because of the hypothermia. When they're hypothermic, there's less of a risk of hypoxic injury to the tissues. The saying goes, you're not dead until you're warm and dead. And again, prevention is the big thing when we come with drowning, making sure that there's some type of drowning prevention program that happens in the late spring and early summer, that we're working to make sure that there's fences around in-ground pools, and then again, safety devices, personal flotation devices, training activities, all of those can help reduce the likelihood of drownings from occurring. Penetrating injuries, an increase in violent crimes has resulted in an increased number of children sustaining penetrating trauma. This is notable now in Detroit and in Chicago and throughout the country. These are unintentional victims. We need to make sure that we do a really good assessment on these folks and do a visual inspection of the external injuries, but recognize that that does not really provide adequate evaluation of the internal injuries. Fluid-filled organs means there's little space. Everything is compact together in these little folks, and so it's more likely that more than one organ can be affected when it comes to penetrating trauma. Again, prevention strategies are critical in this. I hope you're seeing a trend when it comes to how we as EMS providers can make an impact in regards to trauma and peds. Burns are another aspect, and we've talked about these pretty significantly throughout our burn lecture. But children can sustain both burns, injuries, and smoke inhalation in a house fire. So not only do you have a problem with surface area being affected and the ability for them to maintain warmth and those components, you also are dealing with the respiratory problem, and we know how much the pediatric patient needs to have a patent airway and adequate oxygenation. Prevention strategies for this major area emphasis is really on fire departments, teaching folks to stop, drop, and roll, how to exit the house if the house is on fire, smoke detector safety, all those different components that we look at. We know that burns is the leading cause of preventable death for children under the age of 14. And again, the strategies are pretty simple. Awareness, using smoke detectors, and making sure that there's a plan in case the house catches fire for an effective exit strategy. Now, burns is the most common type of burn injury that's encountered by EMS for pediatrics is scalding. Kids playing near the stove reaches up on the stoves and pulls a hot pot of water or something that's on the stove cooking onto them, and they end up getting scalded that way. It could be because of hot water temperatures in the tap or in the bathtub. All those components are there. And we also have to recognize that pediatric patients, specifically infants, will utilize a different rule of 9 than that of an adult. Remember, their body surface area to weight is extremely different. They are smaller, but they have a larger body surface area compared to their overall mass of that like an adult. For burn management, proper management of the airway is critical in their survival. You may need to use endotracheal tubes up to 2 sizes smaller than you normally would, or what will be indicated by your MyMedic, because of the airway swelling that occurs during inhalation burns. We also want to make sure that we maintain body heat, as the integumentary system has been compromised, and now the patient loses their ability to maintain temperature and maintain warmth. With electrical burns, we want to make sure we're looking at musculoskeletal injuries and considering spinal immobilization. It's also possible with electrical burns or injuries that they'll be thrown into a lethal arrhythmia like VTAC. Damaged tissue releases massive amounts of potassium. We know that potassium has a major impact on the sodium-potassium pump and our ability for our heart to produce its normal functioning electrical action potentials. So EKG monitoring is essential in anyone that has suffered from an electrical burn. And use succinylcholine for RSI. It's just not going to be effective because of the excessive amounts of potassium. Physical abuse is another factor that we have to recognize. Again, it's a factor that leads to child abuse from the components we've talked about previously. Poverty, domestic disturbances, younger parents, substance abuse, and community violence are all common reasons why physical abuse occurs inside the home. We also know that children are more pliable, their bones are more pliable, so it's less likely that they're going to have clear fractures, but they can still have a lot of pain and damage to those bones, but not necessarily a compound or a clear fracture that you would expect like in an adult or geriatric. And because of that, their bones are more pliable, meaning that they're less prone to fracture. Now, there are some special considerations when we deal with airway control for a pediatric patient. We know we want to maintain our patient in an inline neutral position as best we can to ensure an adequate airway. We can consider ways of immobilizing them that'll help that by using PD boards or elevating the patient using towels to keep their under their shoulders to keep their airway open as necessary. With trauma, we want to make sure we're administering high flow, high concentrated oxygen per pulse oximetry and maintain an airway with suctioning and jaw thrust where appropriate. We also want to make sure that we're prepared to assist when ventilations are ineffective. When the patient's not able to breathe effectively on their own, we need to intervene. Things that we can consider would be to intubate the child when the airway cannot be maintained, and remember to use your adjuncts, your OPAs, your NPAs to bridge the gap between BVM ventilations and the placement of an advanced airway. We also know that gastric tubes are important. One of the things that you can see in this diagram here is the gastric distension that's occurring inside the abdomen, primarily with the stomach, which is actually pushing up and displacing the diaphragm, making it much harder for them to be able to get air in to the full vital capacity that they will need. Remember, these kids don't have a store of oxygen. They are dependent on that rate and volume with each breath to adequately ensure tissue oxygenation and to reduce hypoxia. We also know that cricothyrotomies are something we can consider, but again are pretty rare when it comes to pediatric patients. One of the big things that we have to make sure that we're conscious of is going to be using the appropriate equipment where it's necessary. It's rarely indicated for traumatic or upper airway obstruction to need to do a needle cric, but if that's the case, we do have to recognize there's a number of anatomical differences between a child's airway and an adult's upper airway. Immobilization is another aspect of things we need to look at. We need to make sure that we're using the right tool for the right job the first time. That means use appropriately sized pediatric immobilization equipment. Keep the cervical spine again in that neutral alignment by placing padding from the shoulders to the hips to kind of elevate that portion of the spine and allow for the head to remain in that neutral position. We also know that fluid management is important. Inserting a large bore IV catheter into a peripheral vein oftentimes is a great tool to use. However, with trauma, we don't want to go ahead and give excessive fluid to pediatric patients, and we also don't want to delay transport to gain venous access. We oftentimes will spend more time than pediatrics IV access because we're less comfortable in it. But remember, don't delay transport. Intraosseous access in children less than 6 years old is typically the preferred route for a critical unstable patient. Remember that with fluid bolus, again, as we discussed earlier, 20 mL per kilogram, and additional fluid boluses may be necessary. If there's no response to a second bolus, assume that surgical intervention may be required to stop a bleed or to control a hemorrhage. Rapid transport would be required. Again, there's more details on this in your PALS manual on page 99, 101, and 102. Pediatric analgesia and sedation is something that's not very common. Pediatric injuries are painful, and if we go ahead and we sedate them, we oftentimes are going to miss or overlook those injuries. There are common analgesics that you can see used, which include fentanyl, ketamine, and morphine. And typically when we're doing pain meds in a ped, do it through an intranasal atomizer. It's going to give you the best bang for your buck, and it's going to stop the child from being more upset because of an IV access. When we think about these commonly used analgesics of morphine, fentanyl, or ketamine, these are going to be typically synthetic agents that appear to have unpredictable responses in children. So we have to be very cautious that it may drop their pressure or that they may have a number of different other side effects because of those narcotics. We want to recognize that certain pediatric emergencies may benefit from sedation. Is there a number of them that you can think of? Head injury or combative with increasing intracranial pressure is one that I can think of. Now, with traumatic brain injuries, the pediatric head injury has different classifications: mild, moderate, and severe. Mild Glasgow Coma Scale is going to be somewhere between 13 to 15, so pretty decent. Moderate Glasgow Coma Scale drops from 9 to 12, and in a severe case, less than 8, we know we got a really sick patient. Remember the saying, less than 8, we'll need to intubate. We also have to recognize the signs of intracranial pressure because in pediatrics, oftentimes the intracranial pressure will rise and it won't have as much of a major impact as we would see in an adult. Obviously, we're going to see elevated blood pressure, bradycardia, and then rapid deep respirations, eventually progressing into slow deep respirations or some type of central nervous system hyperventilation or ataxic or biotz-like respirations. The reason why children can go a little bit longer in this, especially those that are younger, is because the fontanelles are yet to fully calcify and to close. And because of that, it gives it space for the brain to be able to expand as it swells, and it causes the fontanelles to begin to bulge in infants, giving them a little bit more leeway when it comes to head injuries. We also have the time to recognize the signs of herniation, where the brainstem is beginning to move through the foramen magnum. We see things like asymmetric pupils, we see decorticate posturing, as you can see in the upper picture here with the infant, where they're drawing in towards the core, and then as things get progressively worse, we'll see them move to more of a decerebate posturing, as you can see in the image below. Consider hyperventilation here, again, only under the direct feedback from end-tidal CO2, as we know that CO2 actually can be a vasodilator and really make herniation worse. We want to try to get rid of some of that excessive CO2, but it truly needs to be done in conjunction with current trauma standards and monitoring and adjusted appropriately based on end-tidal capnography. When you have a brain injury, there's 3 primary components. Administer high-flow, high-concentrated oxygen. Intubate if the Glasgow Coma Scale is less than 8. Remember that less than 8, we should intubate. Consider using intravenous or tracheal lidocaine prior to intubation, as that will help blunt any increased rise in intracranial pressure. And then consider rapid sequence intubation for children with a Glasgow Coma Scale less than or equal to 8, especially if we need to sedate them to get that tube properly placed. Now with head, neck, and face injuries, these injuries to the head are the most common cause of death in the pediatric trauma victim, right? Look at your book, page 127. Bicycle collisions, falls from trees, car pedestrian collisions, and sports activities, along with abuse, are all very common aspects where you'll deal with head, face, and neck injuries. These diffuse injuries are common in children, while focal injuries are relatively rare. These are often injuries that are going to be spread out versus localized. Now, with facial injuries, we're oftentimes going to find a lack of coordination in children, and that leads to falls. They have slow reflexes as they're younger, and they may not be able to catch themselves, and that can lead to facial injuries. Same thing go for the neck and spine. We know the neck and spine is more pliable, so we may see injuries to the spinal cord without any vertebral damage noted. With chest injuries, we see significant injuries that can occur without external evidence. That's because as the kinetic energy is traveling through the patient, we know their chest wall is thinner, that their bones are more pliable and flexible, and that all allows for the energy to be transferred directly into those vital organs as that energy can travel through those more pliable tissues and structures. Even though we see less obvious injuries, and like things like where the ribs are intact, always can be concerned with internal injuries that may be present. Another one that we look at with the chest is the tension pneumothorax. Diminished breath sounds over the affected lung. We may see things like shifts of the trachea to the opposite side or towards a more effective lung, the good lung. Although that's generally a late sign when you see tracheal tugging. And a progressive decrease in ventilatory compliance. It's getting harder for them to breathe or harder for you to be able to ventilate while using a bag valve mask or endotracheal tube. I know you guys love the pericardial tamponade, so we have to talk about it, right? This is where you see hypotension may be the only sign, where we have the pericardial sac filling with blood from blunt trauma, or even penetrating trauma for that matter. And we have to remember to look for Beck's triad, right? Decreased heart tones, jugular vein distension, and decrease in blood pressure. Now, injuries to the abdomen are another concern for pediatric patients. Again, they got a lot of stuff in a very little space. When those organs are all pushed together, it means that more trauma can happen across more area because of how condensed the organs are. Blunt trauma to the abdomen can result in the injury of the spleen or the liver, and we know that the spleen is the most commonly injured organ in a pediatric patient, and they are both very high in vascularity, meaning they're going to bleed more significantly. There are a number of signs and symptoms that we can see with blunt trauma, but general things would be like a distended abdomen, a hard abdomen, abdominal guarding, or pain on palpation. Splenic and hepatic injuries can also be life-threatening for internal hemorrhage. We know that they're high in vasculature. There's going to be a lot of blood-filled organs, and when those are damaged, that blood begins to release itself into the abdominal organ. A lot of these fluid-filled organs are not as resilient as those that are air-filled. They're solid organs, right? They're more likely to burst or to rip or tear. With the extremities, it's typically limited to fractures and lacerations. We see bend fractures, buckle fractures, and green stick fractures all have to do with the lack of calcification that's happened in the bone, hence the reason why they're more flexible. Some types of growth plate fractures can actually lead to permanent disability, as that extremity will no longer effectively grow at the same rate as the other extremity. Most of the management you'll find is going to be the same as what you would see for adults, paying close attention to make the patient comfortable, using the appropriate mobilization devices, and then being creative where you can in order to ensure proper stabilization of fractures. Now, drowning is an accident in which someone is actually submerged or immersed in a liquid that results in a primary respiratory impairment. About 4,500 persons die annually from drowning, and there's two primary associated factors that typically go along with drowning. That's trauma and hypothermia, and both are prevalent in pediatrics as well. Now, in drowning, if we look at the pathophysiology, following the submersion, the victim will undergo a period of complete apnea. This is about for 3 to 4 minutes. They're going to be holding their breath underwater because they know if they breathe in, it's going to go ahead and it's going to fill their lungs full of fluid. Now, I'm going to talk a little bit briefly about wet versus dry drownings. However, I do want to point out that when we look at wet versus dry drownings, they really are not referred to as wet and or dry issues anymore. Again, we can see that we see a gasping, pulling of the water in is actually going to begin to cause a laryngospasm. This is where a laryngospasm is going to stop additional water from traveling down to the lungs. This is where they used to get that example of a dry drowning. The problem is over a period of time, that laryngospasm will release, especially if the child is deceased and we've gone from a rescue to a recovery. Water will then fill the lungs passively. The big concern you have is that as part of this, the diving reflex, which is going to help prevent you from drowning, is a laryngospasm. Your larynx is going to snap shut, and by doing so, it's going to stop water from coming in. The problem is once you pull them out of the water, that laryngospasm doesn't stop. In order to effectively treat it, you're going to need to slowly ventilate with a two-person bag valve mask technique, trying to slowly split open that larynx or glottic opening to get the air back into the lungs. Gastric distension is another major concern with this because as we try to break that seal, where will the air go? Down the esophagus and into the stomach. Gastric distension is possible. We may have to consider some form of NG tube to relieve that pressure. Drowning is primarily due to asphyxia from an airway obstruction, either caused by a normal response, which we talked about, that laryngospasm, and until ultimately a coma will ensue. Common symptoms you'll see will be hypotension, bradycardia, and death. And there's always been this concern about freshwater versus saltwater drownings. The concern with saltwater is that oftentimes it can pull additional fluid out of the vasculature through the lungs and cause more significant pulmonary edema. One of the things that we know with freshwater drowning is that it washes away the surfactant. Remember, the surfactant is what gives the alveoli their surface tension and keeps them inflated. Salt water is going to draw fluid from the bloodstream and causing more pulmonary edema. We typically see with freshwater drownings from pools or lakes or rivers, ventricular fibrillation where it will occur because of a lack of oxygen, because of hypoxia. With salt water, we typically see more pulmonary edema, but that can still lead to respiratory failure and cardiac arrest. Make sure that if you have a drowning victim that you immediately start resuscitation. We know that factors that affect survival have to do with the cleanliness of the water. Kid falls into an open septic tank and inhales it, that's going to be a much harder route for survival because of infection versus that of a clean pool. Another part that can play a role into this is the length of time being submerged. You can only be under the water for so long before it goes from a rescue to a recovery. The victim's age and general health, and then the water temperature. Believe it or not, cold water drownings have a higher rate of survivability because of the mammalian diving reflex. And cold water slows down the metabolism of the child, slows down their need for oxygen, slows down the damage from hypoxia, leading to a more likely survival. Remember this, you're not dead until you're warm and dead, because cold water drowning patients are not dead officially when they're cold. They are in a state of preservation, if you will. Now, treatment, we need to remove the patient from the water and only attempt rescues if you're properly trained and you have the proper equipment. Remember, reach, throw, row, go. Last thing is to go. We want to initiate ventilation while the patient's still in the water. As soon as you can, begin ventilations. If there's a head injury that's suspected or a neck injury, make sure that we're concerned about spinal immobilization. Also remember that can lead to brain injuries or spinal cord injuries, which can lead to more complications for your pediatric patient. We also know that we need to make sure that they're kept warm, that they're dry. All those are part of that resuscitation effort. So to make sure the patient is prevented against heat loss. And then use your ABCDE approach like we normally would. Manage the airway and use proper suctioning of the airway and associated airway adjuncts. Administer 100% high concentrated oxygen. Keep them warm. Actually consider the use of respiratory warming if it's actually available. Establish an IV. In this case, we're most likely going to use an IV, lactated ringers, or normal saline. Something, again, that's going to be an isotonic solution at TKO. Follow your normal ACLS or PALS protocols if the patient is considered to be normal thermic. And then treat hypothermic patients according to their hypothermia guidelines. The other part we have to recognize is that even though initially we may not have a problem with pulmonary edema, as the process continues and surfactant and fluid that that is potentially in their lungs, it can actually lead to symptoms beginning for ARDS, or adult respiratory distress syndrome, or acute respiratory distress syndrome. I know we talked about a lot of things rather quickly, but trauma is something that's going to happen to pediatric patients. It's important that you have patience, that you adequately assess and perform a systematic trauma assessment as you would with any patient using a body systems approach. We also know that things like falls, pedestrian car accidents, drownings, all those are very common in pediatric patients, but the approach to each patient may be slightly different. And again, as always, pediatric patients are not just small adults. I hope this was helpful for you guys, and we'll look at catching you here on the next one.